I'm Lori Chilma, and with me today is my colleague June Cooper, and we're going to be your host today. So moving on, looking at our objectives for today, teams and teamwork is a huge topic. In ASaP, you're going to be exposed to, and you'll be a member of a number of teams. You're going to be possibly a part of the clinical team, you'll be a part of the improvement team, and you're also members of the local and provincial improvement facilitator team. And you're probably already part of a team in your job outside of ASaP. In today's webinar, we opted to focus our discussion specifically on the improvement team. So why do we choose this focus? The ASaP intervention itself is short, and your opportunity to work with the dynamics of the whole clinical team may not even present for you. But as you'll be working regularly with the improvement team, this is where you may be able to have more influence. So our objective today is to provide you with background and tips to help you create a high-functioning improvement team. Although the content that we're going to tell you about today can definitely be applied more broadly to the clinical teams as well. So we're going to define teams from our perspective in primary care. We'll clarify the difference between the clinical and improvement teams. We'll introduce you to a team development model as it might look in primary care, which is currently being used across Alberta. And finally, we're going to look at trust and communication as two key drivers for team success.
So you may wonder, what's the importance of teams when we look at the future of healthcare delivery? And to put it, succinctly, teams are the future. If you look at this next slide, team-based care is the way primary care is going to be delivered in the future, not just here in Alberta, but nationally and internationally as well. And the document we're showing you can be found in your ASaP Improvement Facilitator Binder in Section A, page 9. And what this does is it outlines the goals that were laid out in 2011 in a position paper that the College of Family Physicians of Canada released. And it's talking about their vision for the Canadian medical home. That's a term that you're going to hear more going forward in healthcare in Alberta. As we've reviewed in a lot of our in-person training sessions, most of these goals, if not all of them, align at least to some degree with ASaP. But today we're going to focus on goal number 3, and it's a little difficult to read there, so I'll read it for you. It says a patient's medical home will offer its patients a broad scope of services carried out by teams or networks of providers, including personal family physicians working together with peer physicians, nurses, and others. We at TOP, through a lot of our work actually, has been promoting the use of multidisciplinary teams in primary care. So, clinical teamwork, if you look at the 2 quotes on there, these are from the Journal of the American Medical Association, and they refer specifically to teamwork in primary care. The first says quality clinical care is not doctor work, it's teamwork. And the second says the best clinical care is not delivered by physician visits alone.
So time for a multiple choice question. What is a team? So A, it's a group of people who work together. B, a group of people who work together to accomplish the same goal. Or C, a group of people who work together in a coordinated way which maximizes each team member's strengths to achieve a common goal. So for those of you that selected C, you are correct. It's a group of people who work together in a coordinated way which maximizes each team member's strengths to achieve a common goal. As you can see at the bottom of this slide, this survey was taken from the IHI Open School, which all of the improvement facilitators have access to, and it's meant to enhance your quality improvement training. This question is actually from the course Patient Safety 103, titled Teamwork and Communication, and it is one of our recommended courses for ASaP, and you'll find those recommended courses in your community practice guide, in your binder, or on the ASaP website. So just to give a little bit of a plug for IHI Open School, if you haven't signed up yet or taken a course, we really do recommend that you take advantage of that opportunity. A lot of great information there on quality improvement. So moving on to the next slide, talking about groups versus teams. I have, once again, shamelessly listed a reference here, which outlines the difference between group and team. And this time, instead of IHI Open School, this one's been taken from your little guide that we provided you in your first day of training, Facilitation at a Glance. So I picked this table out specifically because I've personally referenced it when working with teams. It's a page that I like to flip to. And I usually just like to give a quick glance to it to see if my team is actually exhibiting group or team dynamics. And then I think about what the context is and what I can do about it. So when you look at it, I think some of the comparisons on this table are quite intuitive, like the first line contrasting me versus I focus, or the second line there on sharing a common goal versus having an individual purpose. But I think other factors or examples like focuses on problem solving instead of just information sharing is definitely something I've identified with a team or two after reviewing this list. So in my role as facilitator at subsequent meetings, I started asking questions of my groups to help move them toward problem solving instead of just having them information share and let each other know where all of them are at. So can they dig a little bit deeper and start to problem solve together? So another one that I've worked on in this list is the sharing of the leadership role. So I've suggested to teams to share this role in their improvement meetings. So this is just a couple of examples of how you can move teams from being just a group of people who meet to a high-functioning team. So I hope you can see in your role as improvement facilitator that a brief reflection on your team's behaviors and a few simple suggestions can move them forward toward that level of high-functioning team. You can make suggestions to your teams, and a lot of times they're not going to take your advice right away, or it may not work the first time, but you can definitely begin to plant the seeds with them, which may take root at a later time.
So I'm going to address now what do we mean by an improvement team. You can see on the slide it says clinic team versus the improvement team. The clinic team will encompass all the employees of the clinic that you're working with. The improvement team is comprised of select representatives of that clinic team who are ready and willing to work on improvement goals. So if you're working with a larger clinic, the improvement team may only be a small subset of all the clinic staff. But if you're working in a solo practitioner's office, your improvement team might include everyone. Often, a physician, a nurse, or an MOA, receptionist, PCN staff that they have. So the group would be small enough to include all of them. Some of you improvement facilitators are what we call external facilitators. So that means that you're working with a clinic or even multiple clinics, but you're not a member of the clinical team who delivers care to those patients. There's some of you on the call that we'll call internal facilitators. So that means you're working as a member of the clinical team in addition to having the role of the improvement facilitator for the group. So you're going to be part of both teams, the clinic team and the improvement team. And if we move on to the next slide, who makes up the improvement team? And that's a question we tend to get a lot. So you're a new facilitator, you're working with a group. Say it's a large group, and you're going to select a subset and suggest a subset of those people to make up your improvement team. Just who should that be? So this form on the screen is in your facilitator binder in section B on page 7. It's an optional document. You absolutely don't have to use it, but just like Lori said, there are some things that we've used ourselves in the past when we work with teams in other initiatives, and this is one of them. It helps us to recommend one individual from each discipline to be included into making up the improvement team. Screening can be a part of everyone's role, but this needs to be flexible. And we've seen cases where there are two team members of the same clinic, of the same discipline within a clinical setting, but they play very different roles. And I'll give you an example of that. We worked with a practice that had 2 nurses. So, rule of thumb is at least one of them should make up part of the improvement team. But they had very different roles within that clinic. One of them took care of chronic disease patients primarily, and the other one led women's health group. So it was actually important to have both of them represented at the table. So again, these are guides, but you have to be flexible, look at your team, and see what makes sense within that group. You want to make sure you're not missing anyone who may be a key improvement team member. And a good example of that may be the receptionist. You may not think that they might have an applicable role in some of the proposed changes that you're making with ASaP, but they likely will be impacted one way or another, and they may very well be able to bring some great suggestions to the table. And to exclude them from the improvement team may actually invite resistance to change. Sometimes people like the receptionist role are very key in the changes you want to make. And if you don't get their buy-in, the changes, there can be barriers put up, and the changes can be very difficult to bring about. So your role is to help your improvement teams choose and include the right individuals. If you can, you want to have some champions for change at the table. You'll want leaders who can and will communicate back to their colleagues about what changes the improvement team is going to consider and try out. And then it becomes your job to move forward that selected team. Lori?
Oh, sorry about that. So in this picture here, we have two examples of teams. So consider how these teams might relate to teams in primary care. The top picture is the Canadian National Cross Country Ski Team. At any time, they're made up of skiers from across the country. So this team, they may or may not train together. If one team member is away, it typically minimally impacts the training of the other team members, sometimes if at all. And depending on the type of race they're in when they're in competition, the performance of one team member may not even impact that of the others. The bottom picture is a picture of the Manchester United soccer team from the UK, and they've won an unprecedented number of championships across several leagues. The functioning of this team is quite different from that of the ski team. There's a much higher degree of interdependence. The function of the team is that of a whole, and that's really paramount. So not just solely on the performance of one individual. During a game, the team needs to be very in tune, and all the players need to know what's going on in order for them to score goals to win their game. So it's the football team that really needs to be the high-functioning team here to win. And we know from the literature that the best-performing healthcare systems in the world have quality at their core, and it's their teams that create this quality. So here's a more formal illustration of how a team may be comprised and how they may function. This one here is sort of a program called Healthcare Team Effectiveness that most of us here at top CPAs have training in. So there are three pictures that represent where a team may be at in their phase of development. Phase one is defined as a group of individuals with diverse backgrounds and goals who have no method of working together. In phase two, team members are seeking to formulate common goals, develop relationships, and establish operating methods to increase performance. And the definition in phase three is where team members are focused on common goals, working independently to maximize performance through innovative methods. It's important to note for this that in some instances, one phase is actually not superior to another. Some teams may function really well at a phase one, such as with the ski team. In fact, if you try to take the ski team and work with them and move them to a phase three, you get little return on that investment because they don't need to be performing at that level. But we know primary care is not a ski team, at least us here at top, we don't think so. And we'd ideally like to see our team probably more to strong phase two or ideally into a phase three. But it's important to know when you're facilitating where a team is striving to be. You'll want to know where your team is now, but I think more importantly, it's where they want to be. Primary care teams function, they can function adequately at a phase two, and some may indeed just be content to be a high-functioning Phase 2 team. And other teams may be striving for that Phase 3 shared common goals type idea. So make sure, as facilitator, you have clarity on this so you can facilitate them towards the processes that will actually achieve their goals. So in each of these phases, just want to talk quickly about leadership. The team's leader is represented by the black triangle. And you can see in first one, in Phase 3, that the team is disparate. Typically, but not exclusively, we might see a directive style of leading. So in a group like this, there may be a lot of rules. So people are out disparately working, but they know what their sandbox is. But each team member is doing their own thing. In Phase 2, the leader may be more of a coach. And in Phase 3, the leadership is shared. In fact, if you observed a clinic in Phase 3, you may not actually be able to easily identify who that formal leader in the group is. So that's as much as we're going to touch on leadership today in this webinar. Leadership in itself is a really huge topic. We have provided you with a brief reference on leadership in your binder in G4 if you're interested in learning and reading a little bit more. So what phase are your teams at? So you don't need to answer this, but just think about what phase your team might be in, and do you know what phase they want to be at? So June and I just wanted to give you a couple of examples from our own experiences. So I'll start. I facilitated a clinical team, and they functioned as Phase 1. They were a community outreach team, and they were comprised of therapists who came from several different professional backgrounds. And over the course of more than 10 years, they grew from a couple of members to a team of 18. And they didn't need to work together much. There was little interaction between the team members. It was mostly just consultation with team leads, and they had a physician member that they connected with quite a bit as well. But as access became an issue for the team, they needed to look at streamlining some of their processes, putting some policies into place, and standardizing. And through this process, I would actually argue that they moved from a Phase 1 to a Phase 2 team. June?
Yeah. Oh, thanks, Lori. I'm going to give you an example of a team I facilitated. It was a multidisciplinary team delivering chronic disease management, education, and care. The team consisted mostly of dietitians, CDM nurses, and administrative staff. They had a vague idea of what the other team members did, but they never mapped their workflow, and they never defined roles and responsibilities. So care was delivered in silos. If one staff member went away, no one else could fill in for them. Each team member booked their own follow-up appointments with patients, which led to some underutilization of resources, and they were definitely functioning as a Phase 1 team. So some of the things we did with them, we defined a vision and mission, and that helped to refocus them on what they were ultimately trying to accomplish. We mapped team member roles and their workflow, and that highlighted a lot of redundancies that they didn't even know existed. And it made us realize that different staff members were actually capable of doing some tasks that were being currently done by others. So cross-training and standardization of content really helped. And this allowed for coverage when a staff member was absent as well. All the booking was shifted and started being done through the receptionist, so there was a better utilization of time, and that speaks to having the right person doing the right job. Everyone was clear on their roles and responsibilities. Each played a part based on their scope with clear common goals in mind. The team came to realize that improved patient care and outcomes were not fully dependent on one person at all, but as a result of their team effort. So the end result was actually a level 2 to 3 team. Now, if you look at this next slide, this is another great illustration found in healthcare team effectiveness, which Lori and I and the other clinical process advisors from TOP have training in. And this poses that there are 3 team dimensions that need to be assessed and addressed to reach the level of function that the team wishes to achieve. And I'm going to underline there that the team wishes to achieve. Just as Lori said previously, it's not only important to know where your team is at now, but where they want to get to. You'll note as well that in this illustration, trust is at the very center of it all. We'll go over each of these dimensions in turn, outline some examples of some of the elements that comprise them. As you're the improvement facilitator with teams, you want to be able to identify the elements that may need to be addressed with the team as they improve their level of functioning. So they may be strong in methods and alignment, but be lacking a bit in relationships, for example. So on to the next slide, we're going to deal with relationships first. So it's the first dimension that we're going to consider, and we're going to take a closer look at the first two elements listed here under relationships: values and norms, and interpersonal communication. Defining values and norms is not something that a lot of clinical teams do before they either reach a point of crisis or before they start working with a facilitator on an improvement project. It's more of a touchy-feely exercise, and it can seem to some like a frivolous use of time. You know, you work in a busy clinic, I don't have time for that. But taking a few minutes to have the team reflect and define what is important to them and how they behave can be invaluable. An example of a value might be respect for other team members, and the associated norm with that would involve ways to put that value into practice. For one team, it might be as simple as stating that cell phones are turned off during meetings. How much help and guidance they need in this regard depends on the team. There's lots of tools available to help, and we urge you to discuss it with your top CPA. Communication is another important element. We're going to discuss it a little further in a few minutes. Active listening, understanding and clarifying, making eye contact, being non-judgmental, allowing the other person to finish their thoughts and sentences. They're all examples that describe communication in a high-functioning team. As the improvement facilitator, you can actually model this behavior. That would help. Or you can assist by reminding team members of the agreed upon terms if the situations warrant.
The next dimension on this triangle is methods. And one of the elements in this list I want to bring to your attention is meetings. When we look at the table earlier from facilitation at a glance, we suggested that a team holds regular meetings. But we also want to ensure that these meetings stay on task and that they're productive and value added for the team. The improvement facilitator is really key in helping teams with this. Again, more information on meeting management can be found in your Facilitation at a Glance booklet. We really suggest you take a look at that. The second element of methods that I want to highlight is what some of you are already experiencing in ASaP, and that's the integration of new team members. Teams change. Someone new may be hired into the clinic, or someone just might be reassigned to the improvement team that you're working with. And it's important to ensure that the new member is brought up to speed on where things are at and that they're clear about their role that they're playing on the team. So if they should have access to documentation, including things like if there's the previous agendas and meeting minutes and the PDSAs to date, which is really a great reason to urge your teams to be documenting what they're doing. So alignment is our third and final dimension. So let's talk about mission and vision, which June actually talked about in her example just a few slides ago. So this can be a similar challenge to defining team norms. It may feel a little bit soft or right-brained for a lot of physicians, but it really can be a great exercise, especially as teams begin ASaP. So if we could just reiterate, what is their vision and mission for the clinic? Then if it's something, typically when we see vision and mission, it's usually something around providing excellent and proactive care. And what you can really do is take ASaP and align this to their vision and mission. And if they don't have it, you can help them define it and then show them how that links to ASaP. So typically it can be really helpful and motivating for a team to know what it is they're striving for. And then a mission and a vision really gives that to them. And once again, more information on this can be found in your Facilitation at a Glance booklet. The second item in this list I wanted to highlight is roles and responsibilities. And that is, does everyone know what their role is on the team? So they may be quite clear on their clinical role, but the role on the improvement team is likely different from that of their everyday job. So you just want to make sure when you're working with the team, do you know who is responsible for booking the meetings, taking minutes, leading a PDSA, entering the data, collecting the data, and then there's the improvement boards. We want updated every week so people keep coming back to it, and any other the tasks that are involved with ASaP. So as the improvement facilitator, if you take the time to define this and who will follow up, it can really strengthen the alignment on your team.
I love this next slide. So if we're talking about trust and you're looking at that menu, which would you trust, chicken or real chicken? Would you consider the price on each before making that decision? Well, just like with this menu, trust is essential to team success. Trust is measured by the degree of safety and security that team members feel towards the leader and towards one another. The team also needs to trust you as the facilitator. You can't have total control over the behaviors of others on the team, but you can facilitate and influence behaviors that can build trust. So let's use an analogy of a bank. Instead of a savings account, though, we're going to imagine trust accounts. So you, as the improvement facilitator, need to establish and maintain trust with your teams. So how do you build up a balance in your trust account? Well, you can make deposits by being open about your feelings, sharing ideas, making clear your intentions, deliver on your promises. That's a huge one. Listen and share the credit, especially, when things are done well, share the credit with the team. But you can make withdrawals as well. And those are made by failing to keep a confidence, failing to meet your commitments, things that you said you were going to do and you didn't go through, providing lack of support during crisis. It's been said that you have to have 3 deposits on hand for every withdrawal you make for things to balance. There's an excellent book by Stephen Covey Jr., whom many of you I'm sure have heard of, and the topic is called The Speed of Trust. The book's main message is that when trust is strong, you can move quickly to achieve your goals. And it's something that as the facilitator of a team, you really need to work on. Lauren?
Thanks, June. So we promised you that we'd come back to communication. Communication is a really critical factor in a high-functioning team. So at risk of sounding like a broken record, I am going to tell you that Facilitation at a Glance has numerous sections on enhancing communication with your team. But sometimes something teams often enjoy is an experience with the personality theory exercise. It's also something that I found can really stick with the team for a long time. There's several personality theories out there. They're intended to help you understand and appreciate yourself and others. They help us to see how we like to be communicated to and how we like others to communicate to us. So the example we put up here on the slide is the True Colors program. And to provide an example, you will be fill out a survey and be assigned a color. And in this example, a blue team member is a compassionate and emotional individual. So a blue person will remember on Monday that you were taking your son to a baseball tournament on the weekend. And when you get back to work on Monday, they'll ask you how it went. If you contrast this with the analytical green person, they get to work on Monday to get the job done and not to socialize. And they may not reciprocate the blue's desire to debrief on how the weekend went. And this can make the blue feel a little blue. And the green person may get annoyed at the blue for not getting down to business. So it's just a quick example, but we want to illustrate the goal of these exercises is not to get people to change who they are. It's to make you understand and appreciate the other team members, how they think and problem solve, and how they approach their work, and how they like to give and receive information. It can really help with team communication and interpersonal relationships. So several of these programs have free online surveys, or you can pick up a book. There's usually quizzes you can have each member take. But as improvement facilitator, it is good to facilitate a discussion with teams on what the outcomes were so they really understand the results. So I've seen people do a whole day workshop on this, or just even do a really quick 15 to 30-minute exercise on this. So if you have any more questions about doing something like a personality theory exercise, you can consult your CPA who can help you with accessing some resources for this. So we talk about communication and the improvement board in all 3 of our in-person training sessions, and that's for a good reason. First, communication is one of the 4 high-leverage changes we're proposing for ASaP, and communication really needs to be enhanced to accelerate the improvement in screening practice. The improvement board is something that we promote as a communication tool for team members. We recommend it includes your aim, your measures being used, your current system performance, and of course the run charts to demonstrate your results. The pieces of the board that are changing is what actually keeps people coming back and interested in what you're doing. And the run charts are one of these items that we've talked about, where we keep every day we add onto that chart, or sorry, every week we add onto that chart where a team is at. But teams can really be creative. We've seen teams who've included a weekly joke that makes people come back and read the board, or sometimes they do something a little bit more personalized for their clinic, and they'll include a picture of someone on the team and a message about the improvement task and the role that they're playing on the team. It's really up to each team and whatever works best for that team. So just some considerations for the improvement facilitator. We've really just provided you with tidbits and really just scratched the surface on teams today. We recommend you keep your finger on the pulse of your team as they move through the ASaP initiative, and really use the resources you have in your top CPA in IHI Open School and Facilitation at a Glance to decide what those best approaches are and the best resources that are for your team.
So in summary, we don't expect you to know everything all at once. Facilitation is a learned skill, and it improves just like every other skill in life as you practice it. If you develop a good professional relationship with your teams and you remain open and listen well, you'll start understanding where they are and where they wish to go. And you're not in this alone. We are here to back you up. Please use your resources that Lori mentioned, but especially your clinical process advisor. Especially at the beginning of your journey as a facilitator, we're here to have your back and help you as you learn to go along. So thank you for calling in today. We certainly hope that you've enjoyed and got something out of our presentation on Teams. Lori, do you have anything else to add?
No, that's great, June. Thank you very much for wrapping us up today.